Hello guys, how are you? Hope you are doing fine. Welcome to our channel Last Minute Pharma, your exam antidote, presenting you with a new series of Pharmacology 2. And today we are going to discuss about antiplatelets. Okay, one of the very important topic, very simple to understand, and we will make it the easiest way to remember all the drugs which are there of antiplatelets over here. Okay, by understanding each and every bit of the platelet aggregation, then what are antiplatelets, and we'll be going in detail. Okay, so before starting, what are these antiplatelet drugs? Okay, these antiplatelet drugs are those drugs which are going to inhibit the platelet synthesis and they are going to inhibit the aggregation of the platelets. Okay, so the question comes, why do we have to stop the platelet aggregation, or why do we have to reduce the platelets? Usually platelets are good, right? But why do we need to reduce it? But in certain condition, when there is a unwanted coagulation of a blood, or unwanted clots which are formed in the peripheral arteries we talk about, or in deep vein thrombosis situation if we talk about, or if we talk about the cerebral coronary artery disease if we talk about, if there is an unwanted clot, then that can lead to decrease in the blood supply, right? So for those type of situation, like your deep vein thrombosis or any other thromboembolic disorders, we are going to use this drugs, that is your antiplatelet. Okay, so these antiplatelet drugs are mainly used for treating the thrombo or thrombic disorders. They are mainly used for treating the thrombic disorders. Okay, so before going into deep about antiplatelet mechanism of actions and everything, let's try to understand the normal physiology. How does this platelets act? Okay, so now in the blood vessel you are having your endothelial tissues, or endothelial cells are over here, right? So these cells which are there, they are going to release your nitric oxide and then your prostaglandins. So try to understand the function. This nitric oxide which is there, this is responsible for your vasodilation. This is responsible for your vasodilation. And one very interesting phenomena what this prostaglandin do is that this prostaglandin which is there is going to bind to the platelets. These drugs which are there, this prostaglandin chemical mediator which is there, which is naturally released, okay, which is naturally released by your blood vessel, is going to bind to the platelets and is going to inactivate them. Usually when there is no injury, why do we need platelet to function? What's the main function of platelets? It's going to help in whenever there is a blood leaking or an injury, it's going to help in preventing the blood loss. But normally, when the blood is flowing, do we need the platelet activity? No, right? So that's why your prostaglandin, which is released by the vascular endothelium, is going to bind to the platelets and is going to inactivate the platelets. As simple as that. But now, when there is going to be an injury, okay, now when there is going to be an injury, now the collagen fibers which are there, okay, you know collagen fibers, right? So the collagen fibers, these fibers, just try to imagine these are nothing but your collagen fibers. These collagen fibers, when there's an injury, these collagen fibers are exposed to the blood vessels, or they're exposed to the bloodstream. So when they're exposed to bloodstream, what will happen? This will going to attract the platelets. These collagen fibers are going to attract the platelets, and once it starts attracting, or once there is a linkage between this collagen tissue or the collagen fibers and the platelets, in the platelets, so see, now I'm zooming this platelet. Okay, this is nothing but the red color which you can see over here is a zoomed in part of a platelet. Okay, so what has happened over here? Injury has happened. After injury, what has happened? It has gone to the collagen fiber which has been exposed because of the injury. So what is going to happen? These platelets are going to get activated. So when I'm telling the platelets are going to get activated, what does that mean? That means that there are some granules which are there in the platelets, okay, and they are responsible. Once if they get activated, once they get exposed to the collagen fiber, then what is going to happen? These granules which are there, they are going to release your ADP. They are going to release your ADP. Then it can release your thrombin. It will release your serotonin. It will release the ADP is there, serotonin is there, and thrombin is there. Okay, now these mediators, these are nothing but the chemical mediator, and one of the very important mediator also is there, is here platelet activating factor. That is your platelet activating factor. So these are the chemical mediators. These are the chemical mediators which are being released by the granules. When is it released? When there is an injury, collagen is exposed, and once it goes and contracts or once it goes and attracts the collagen fiber, then these mediators are released. There is a serotonin, ADP, thrombin, and platelet activating factor. So platelet activating factor obviously will start the proliferation of the platelets, because more and more platelets have to come and help in the clotting process, right? That is okay. But now over here, try to understand this ADP which is there. Okay, adenosine diphosphate, this ADP which is there, this is going to go and bind to this receptor, that is your P2Y12 receptor. Okay, once the granules are released ADP, this is going to go and bind to the P2Y12 receptor. Now once this P2Y12 receptor is activated, when will this get activated? When will the P2Y12 receptor get activated? When there is ADP. And when the ADP is going to come? When there is an injury. Okay, very simple. So what is going to happen? ADP which is there, this is going to bind to the P2Y12 inhibitor. Okay, now once this P2Y12 inhibitor is activated, this P2Y12 activator which is there is going to activate your GP2A3B receptor. Okay, once this GP2A3B receptors are going to get activated, what is going to happen? The fibrinogen which is there, okay, the fibrinogen which is there, okay, so fibrinogens which are there in the normal blood, right, they are nothing but the plasma proteins, yes or no? Is there in the plasma proteins? See, platelet is there, ADP has been activated, then it will activate your GP2A3B receptor. So what will happen? Normally in the blood even fibrinogen is there, yes or no? So these receptors will go and bind with the fibrinogen, and this fibrinogen which is there will act like a cross link. It will act like a cross link between the platelets. Now here again you will have different platelets. I'll just draw it over here. Again this is a GP2A receptor. Okay, sorry, the receptor molecule. Okay, this is again the receptor molecule over here, and again you are going to have a, I'm just zooming in, there is no space, so this is again a platelet molecule. Okay, and when are these receptors which are there? Please note over here, when are these receptors going to get activated? When your P2Y12 receptor is activated. And when is your P2Y12 receptor activated? When there is ADP. And when is the ADP? When there is going to be granule secretion. And when will the granule get secreted? When will the granule get stimulated? When there is a injury. And this is how it happens. This is how the platelets are going to aggregate to each other, and then going to show you the coagulation. Not coagulation actually, the clotting process. That is going to show the clotting process. But now, what is the thing? We are looking for the antiplatelet. Now we have to, if you understand this clearly, if you understand this phenomena clearly, then we can think where all we can use the drugs, what all the activities or the phenomena we can prevent to show the antiplatelet therapy. Now let's go and understand about the antiplatelet therapy. So I hope now we are clear with the normal platelet aggregation, how it takes place, okay. So now we are going to see how the antiplatelet drugs are going to inhibit this normal platelet aggregation. So now just giving you a glance of that, what has happened, just a review of it. There were some chemical mediators which were released like a serotonin, thrombin, platelet activating factors, ADP, and then what we have seen that this ADP is going to activate this P2Y12 inhibitor, and P2Y12 receptor. So once this receptor is activated, what is going to happen? This is going to go and activate your GP2A3B inhibitor, and once this GP2A3B inhibitor is activated, this is going to promote the, what is it going to promote? The fibrinogen cross linkage. This is going to promote the fibrinogen cross linkage, and once the fibrinogen cross linkage is initiated, then what is going to happen? There is going to be the platelet aggregation, as simple as that. But now let's try to understand what are the different drugs available to inhibit this platelet aggregation. What are there are these type of drugs which are there, they are called as antiplatelet drugs. Okay, so now if we talk about the arachidonic acid pathway, okay, so what is going to happen in arachidonic acid pathway? You're going to have your you're going to have your COX enzyme, COX1 and COX2. So after activating your COX1 and COX2 enzyme, what is this going to get converted? This is going to get converted into other prostaglandins, prostasynthesis, yes or no? Prostaglandins are going to get one of the major component which is responsible for the platelet formation is your thromboxane, A2. And I hope you all know the arachidonic acid pathway. That's why I'm not discussing. That's why I told you we're discussing for pharmacology too. Okay. So now over here in arachidonic acid pathway, what is going to happen? This COX enzyme is responsible for getting converted into thromboxane A2, and this thromboxane A2 is responsible for platelet formation. But now we have certain drugs which are going to inhibit this COX enzyme. Which are those drugs? Very famous drug, that is your aspirin. This aspirin which is there, this is going to inhibit this. This is going to inhibit the COX enzyme. And if you are inhibiting the COX enzyme, what is going to happen? The thromboxane A2 will be decreased. The concentration of thromboxane A2 will be decreased. And if concentration of thromboxane A2 is decreased, then what will happen? Obviously, you will not be having the platelet formation. Now, other mechanism which is up there for the antiplatelet therapy, or that is your P2Y12 inhibitors. Okay. Now see, usually what is happening over here? Normally without antiplatelet therapy, your ADP is there, and this is going to bind to the P2Y12 receptor and get activated, and then go activate a GP2A3B receptor. But now, what if I tell you that we have a drug which is going to block this particular site? If you block this site, okay, I am going to block this site with my P2Y12 inhibitors. I am going to block this site with the P2Y12 inhibitor. If I am going to block this, then what is going to happen? This ADP which is there will not be able to bind to this particular receptor. So if it doesn't bind to this particular receptor, what is going to happen? This P2Y12 receptor is going to stay inactivated. This which is there is going to stay inactivated. And if P2Y12 itself is not activated, how will it activate your GP2A3B inhibitor? Is it making sense to you? So those drugs which are there, which are going to inhibit your P2Y12 receptor, that is your clopidogrel. I'll just write down over here. Clopidogrel. And then you're having your ticagrelor. Then you're going to have your ticagrelor. Okay, so these drugs which are there, that is your P2Y12 inhibitor, is going to inhibit this ADP to bind to this receptor, and hence will make this P2Y12 stay inactivated. So this is one of the pathway, or this is one of the way how the antiplatelet therapy can work. Fine, well and good. Let's go for next. Now over here, you are having your GP2A3B receptor. Okay, so now there is one more chance. What if I block this receptor? If I am going to block this receptor, what is going to happen? If I am going to block this receptor, what is going to happen? The fibrinogen linking which is there, over here you can see that it is responsible for the platelet aggregation. If this linking itself would happen, how will the platelet aggregation take place? And that is what is our goal. We are using antiplatelet. That unwanted clot should not happen. That's why we are going to block this. And these drugs which are going to block the GP2A3B inhibitors, these drugs are called as GP. The name itself tells everything. 3B inhibitor. Now over here we are going to discuss about the GP2A3B inhibitor. Okay, so what are these drugs going to do over here? See, this GP2A, if it's activated, what is going to happen? This is going to lead to the fibrinogen cross linkage, and this is the main fellow, right, which is going to help in the aggregation, platelet aggregation method. So now there are certain drugs which are going to inhibit this aggregation. There are certain drugs which will going to prevent the cross-linking of the platelet, or cross-linking of the platelet aggregation, okay, or fibrinogen cross-linkage. And those drugs which are there over here, that is your epitifabatide, and then you are having your epcicimab. These drugs which are there, they are going to inhibit this particular receptor, and if this receptor is inhibited, then what is going to happen? The fibrinogen cross linkage which is there, that itself won't happen, and that is how we can show the antiplatelet activity. Now one more method is there over here, that is your PDE enzyme. This PDE enzyme which is there is responsible for converting your cyclic AMP to your AMP. Okay, so now what is this? There are certain drugs which are going to inhibit this enzyme. There are certain drugs which are going to inhibit this enzyme. Okay, so I'll just erase this part. It will be easy for need to explain over here. Okay, I hope this thromboxane A2 mechanism is clear. Okay, so now over here there are certain enzymes which are called as your cilostazole. Okay, cilostazole. So this is one of the enzyme which is going to inhibit this phosphodiesterase enzyme. Okay, and this enzyme is responsible for converting your cyclic AMP to your AMP. But now over here you have to understand very important thing over here is that if you are inhibiting this enzyme, then what is going to happen? The concentration of cyclic AMP is going to increase, and if cyclic AMP concentration is increased, then what is going to happen? It is going to lead to decrease in the calcium. It's going to lead to the decrease in the calcium concentration, and this is what is going to lead to vasodilation. This is how it's going to lead to vasodilation, and then further it is going to act as it's going to prevent the platelet aggregation. This is going to prevent the platelet aggregation. I hope it is clear. What is happening over here? These drugs which are there, like cilostazole which is there, is going to inhibit your phosphodiesterase enzyme, and because of that the cyclic AMP concentration is going to increase, and once cyclic AMP concentration is increased, it will decrease the calcium level, and decreased calcium level will lead to vasodilation, which is responsible for showing the anti-platelet activity or the anti-platelet aggregation. Okay, the platelet aggregation is what is going to be prevented in this case. So these are the different ways, okay? These are different ways or different phenomena or different mechanisms how your anti-platelet drug is going to prevent the platelet aggregation. Now, in detail, we'll be listening or we'll be hearing about we'll be classifying the anti-platelet drugs. See, it's the same thing, but I'll just give it a more in a systematic way, the mechanism of action and the examples of the drug, which is a very important in the easiest way. Let's go with that. So now we will detail understand about the antiplatelet classification, antiplatelet drug classification. I hope the mechanism of action is completely clear. With that one diagram you can understand each and everything. Okay, this is just a written format for you to understand in much more detail and keep in your minds. Okay, so see, mainly the antiplatelets which are there, they are classifying it into 4 classes. That's your COX inhibitor, P2Y12 inhibitor, GP2A3B inhibitor, and your PDE inhibitor. Sorry, I forgot to write inhibitors. Just write down. Okay, PTE, phosphodiesterase enzyme inhibitor. Okay, so these are the major classes of the drugs which you are going to have. Now the examples you can remember for COX inhibitor is your aspirin, P2Y12 inhibitor which is there. Remember P2Y12 inhibitor instead of ADP. Instead of ADP, this drug is going to go and bind and block the mediator, right? So what is going to have? You are having reversible also, irreversible also. Reversible one which is there, you are going to have your clopidogrel, and irreversible which is there, that is your ticagrelor. Now, next is your GP2A3B inhibitor. That's nothing but the linkage, the fibrinogen linkage which is there. That is what we are going to prevent if you are going to give this drug. Okay, so in this you are going to have this synthetic molecule also is there, monoclonal antibody is there, there is an abciximab, and then you are going to have your eptifibatide. Okay, so these drugs which are there are mainly going to be used as a GP2A3B inhibitor. Now, then you are going to have the drug which is your cilostazole. Okay, this cilostazole which is there, this is going to act as a PDE inhibitor. So see, mechanism of action is clearly written over here. Okay, your PDE inhibitor, what is it going to do? It's going to increase the cyclic AMP level, right? Because it is going to inhibit, what is this PDE inhibitor going to do? It's going to inhibit this phosphodiesterase enzyme, and if you are inhibiting this phosphodiesterase enzyme, now what is going to happen? Cyclic AMP won't be able to convert into AMP, so cyclic AMP concentration will increase, and once the cyclic AMP concentration will increase, it is going to lead to the antiplatelet effect. Okay, then later you are going to have your GP2A3B inhibitor. It's going to prevent the main thing, fibrinogen linkage or the platelet cross linkage over here. And then if we talk about the P2Y12 inhibitor, is going to block the P2Y12 receptor, which is going to inhibit the ADP molecule to come and activate. Okay, it will not, if ADP molecule doesn't come, the activation won't happen. Okay, and if activation doesn't happen, it won't stimulate your GP2A3B receptor. Okay, and then the arachidonic acid pathway, where you're going to have the COX inhibitor, that is your aspirin, which we studied. So what is going to happen if you're inhibiting the COX? Then what will happen? Your thromboxane A2 will be there, and this thromboxane A2 which is there is a potent promoter of a platelet aggregation, and if we inhibit this, yes, we can get the activity, that is your antiplatelet effect. Okay, so main thing you can remember, how to remember this antiplatelet drugs. See, you remember, you all when you were in kids, you have eaten Parle-G, right? So we are making a new brand over here. That is your Popcorn G. That is your Popcorn G. Okay, so what does this Popcorn G stands for? What does this Popcorn G stands over here? Try to understand. The P which is over here, this is going to stand for your P2Y12 inhibitor. This is going to stand for your P2Y12 inhibitor. Then this P which is there, this is going to stand for your PDE inhibitor. And later if we talk about your CON, over here CO, this is going to stand for your COX inhibitor. And then G which is over here, okay, G which is over here, this is your GP2A 3B inhibitor. So one major thing you remember, all these are going to be inhibitors. Okay, all these which are there are going to be inhibitors. P2Y12 inhibitor, PD inhibitor, COX inhibitor, G and GP2A3B inhibitor. Okay, so this is a code which you can remember. Popcorn G. Parle-G everybody has heard, but now we are having a new brand that is your Popcorn G. Okay, I hope it is clear. Okay, this is a classification of the drugs of the antiplatelet. This is the mechanism of action, and mainly if I talk about the ADR of these drugs or behind antiplatelet drugs, the major area which is there with almost all of this drug is that bleeding risk is there. Bleeding risk is there. So patients who are having peptic ulcer disease or any bleeding disorders or some deficiency of clotting factors, these cannot be given. These drugs which are there should not be given, and if you are giving it, it should be monitored closely. Okay, I hope you understood that. Okay, so this is what it was, and mainly over here the uses. What are the major uses where you are going to use this antiplatelet drugs over here? You are going to use it ACS, acute coronary syndrome. Coronary artery is blocked. So for that, because of unwanted clot, you want to stop the platelet aggregation, and this is what you will use. Okay. Then your peripheral artery disease. Okay. In that conditions also we can use this drug. The patient who are going to have the risk of MI, these antiplatelet drugs which are there are proven to reduce the risk of this myocardial infarction. And then the last, the ischemic stroke is what it is going to inhibit. Now one more idea you can remember for this silestazole especially, okay. So silestazole, what is silestazole? Silestazole is nothing but you are mainly taking it as your PDE inhibitor, okay. This has a slight area, that is your headache, okay. This PDE, which is this PDE inhibitors which are there, they have a very common area that is going to cause headache over here. But the major common area which this all the antiplatelet drug is going to have bleeding, okay. So be careful. If you are giving this drug to a patient who is having peptic ulcer, it should be monitored closely. Or if any bleeding risk is there, it should be monitored closely. So this was all for today. Complete antibiotics in one shot. Okay, I hope you understood. Like, subscribe. In the upcoming lecture, we'll be discussing about the anticoagulant agent with more interesting codes. Okay, so I hope you understood. Notes are available. Kindly avail the notes. Join our Telegram channel. We have started our new Instagram channel. We'll be posting more and more reels also regarding different types of diseases. So stay updated, stay with us, learn, and goodbye.